Good afternoon and welcome to our third series in our 2021 healthcare webinar. Thanks for joining us. We are, of course, sad that we can't join in person, and we're looking forward to, fingers crossed, everything goes right. Hopefully we'll be in person with you all in the spring. I'm Paige Masters. I am an attorney with Crowe and Dunleavy in our Oklahoma City office. And today we'll be talking about trending reimbursement issues, including surprise billing, price transparency, and a whole lot more. So presenting with me today is Alison Howard, who is an attorney at Crowe and Dunleavy as well. She's the chair of our ERISA practice group. She's going to be talking about mental health parity, reference-based pricing, and COVID surcharges. And then Bill Clark from BKD is joining us to talk about the proposed revisions to Medicare cost reporting requirements. So we've got a lot to cover today. We hope to have an opportunity for Q&A. If you have a question, you can submit those questions through the Q&A. If we don't have time, we will be happy to address any questions you have via email after today's webinar. All right, well, I am going to focus on the No Surprises Act. Click on through. And for those of you who aren't as familiar with the No Surprises Act, it was signed into law on December 27, 2020 as part of the Consolidated Appropriations Act of 2021. It addresses surprise medical billing, just as it sounds. This is also referred to as balance billing, and it's, of course, a focus at the federal level. Balance billing occurs when a payer does not cover the entire cost of the patient's treatment by a non-participating, or also known as out-of-network provider, and the patient receives what they call a surprise bill, making up the difference. The Act prohibits balance billing for provision of emergency services by out-of-network providers across the board, and largely prohibits balance billing for the provisions of non-emergency services by out-of-network providers at in-network facilities. So the typical situation that this act is designed to address is when a patient has a heart attack and is rushed to the nearest hospital for emergency care, and that hospital does not have an agreement with the patient's health plan specifying what the payment will be to the hospital in that situation. The hospital therefore bills its usual and customary charges. Typically, those charges are much higher than an in-network rate, and then the patient's portion of the bill is much higher than it would have been had they been taken to an in-network facility. Whereas bipartisan support for the legislation has broad public sentiment, because the view is that the patient should just not be penalized in this situation. So while it offers significant protections to patients, at the same time, it imposes significant burdens on plans and providers to comply with the law. The Act amends the Public Health Service Act and makes corresponding changes to ERISA and the Internal Revenue Code. The Departments of Health and Human Services, Treasury, and Labor are tasked with issuing regulations and guidance to implement its provisions. And these departments have published 2 sets of interim final rules and 1 notice of proposed rulemaking. Most of the sections become effective on January 1st. The only exception to this is the HHS enforcement of the provider facility good faith estimate that we will briefly discuss in a bit. So as I mentioned, the Act primarily applies to emergency services, as well as some non-emergency services provided by out-of-network providers at in-network facilities. So under the Act, health plans and issuers covering benefits for services in a hospital's emergency department or a freestanding emergency department must cover emergency services without the need for prior authorization. And when services are provided by an out-of-network provider or facility, the health plan or insurer must cover the emergency services as if they were in-network, meaning without any more restrictions or limitations and at no more than the in-network cost-sharing amount. The Act prescribes a process for determining patient cost sharing, which would include co-payments, co-insurance, and deductibles. A plan is barred from imposing a greater cost sharing requirement than would be imposed if the services were provided in network. And the Act uses the terms recognized amount and qualifying payment amount, also referred to as QPA. So if you hear me say QPA, that's what I mean. Patient cost sharing is calculated as if the total amount that would have been charged for such services by a participating provider or facility were equal to the recognized amount. And that amount is defined as the amount that is required under any state law that applies to the situation or service, or the amount established through an all-payer rate setting model, or the qualifying payment amount. Qualifying payment amount is defined comes down to really a market-based median in-network rate, determined based on historic rates between the plan and the provider, or if unavailable, an independent database of historic payment rates for such services. The departments in July released or published interim rules that set forth a process for determining qualifying payment amount. I would encourage you to review those. The law allows also for this median contracted amount is increased each year based on the consumer price index. So as an example, if a patient generally owes a 20% copay for emergency services, the patient will pay 20% of the recognized amount, meaning the amount required under any applicable state law, or the amount established through all-payer rate setting model, or this qualifying payment amount. QPA will apply to patients covered by self-funded health plans because they are not subject to state regulation. Also importantly, any cost-sharing payments made by the participant or beneficiary must be counted toward their in-network deductible or out-of-pocket maximums in the same way as they would have been if they were treated by a network provider or at a network facility. So, as I mentioned earlier, the Act is, of course, designed to put an end to balance billing. And when emergency services are provided by a non-participating provider or facility, the entities may not balance bill under any circumstances. The Act likewise generally prohibits balance billing for non-emergency services furnished by non-participating providers in a participating facility. It's kind of a tongue twister, but by non-participating providers, they mean out-of-network providers. However, the law does allow out-of-network providers to issue notices to patients and bill them in excess of the cost-sharing amounts imposed by the plan, provided the non-participating provider obtains consent from the patient 72 hours in advance. The patient has to sign a consent to receive the services from the out-of-network provider and acknowledge that he or she has received the written notice. However, the Act specifically excludes services furnished as a result of unforeseen urgent medical needs that arise after the patient has consented to the out-of-network care. And you cannot get consent for out-of-network rates for emergency medicine, anesthesiology, pathology, radiology, neonatology, and diagnostic services. So how does the out-of-network provider get paid? The health plan or health insurance issuer must either make an initial payment or send notice of denial of payment within 30 days after the provider transmits the bill for services. The Act does not define what amount should be paid by the health plan as an initial payment. Payments are made directly to the provider or facility at an amount equal to the out-of-network rate minus the patient's cost-sharing amount. Out-of-network rate is likely either the rate agreed to by the plan or provider or the rate determined through an independent dispute resolution process. The independent dispute resolution process was the focus of interim rules released just a few weeks ago on October 6th. The Act establishes a negotiation process followed by independent dispute resolution if negotiation is unsuccessful for plans and providers in establishing an out-of-network rate. So like I said, you have the health plan has 30 calendar days after the provider sends the bill to make an initial payment or deny the claim. Within 30 days of receipt of that payment or denial, the provider has to initiate negotiation. This period lasts about 30 days or lasts 30 days. To initiate the negotiation period, the initiating party has to send a required form with information sufficient to identify the services in dispute. This includes information regarding the items or services subject to negotiation, including the date the item or service was furnished, the service code, the initial payment amount or notice of denial of payment, an offer for the out-of-network rate, and contact information of the parties sending open negotiation notice. If the parties fail to agree on payment during the 30-day negotiation period, any party may initiate the IDR process, and the disputes are decided by a certified IDR entity. The Act directs the Secretary of HHS jointly with the Secretary of Labor and Treasury to establish regulations for the IDR process, including criteria for certifying IDR entities. As I mentioned, the departments did publish a set of interim rules on October 7th, not 6th, that include details on this process, and comments to the rules have to be submitted, may be submitted until early December. Under the proposed interim rules, to initiate IDR, the initiating party will submit a notice through the federal IDR portal, which is a public website that will be maintained by CMS. And this notice must be submitted within 4 business days following the end of the negotiation period. In the notice, the initiating party has to identify its preferred IDR entity and include information such as the service at issue and the qualifying payment amount. Certified IDR entities are selected by CMS and have to meet certain requirements, like maintaining accreditation for conducting payment determinations and having processes to assess conflicts of interest. They also have to have sufficient medical, legal, and other expertise and sufficient staffing to make determinations on a timely basis. The departments will make available on the portal a list of the certified IDR entities among which parties to the process can select. And this will include just basic information about the entity, such as contact information, their certified number, which will be a unique identification number assigned by the departments, and their service areas. In their interim rules, the departments indicated that the certified IDR entities will most likely be limited to organizations with sufficient staff who have arbitration and healthcare claims experience, including those currently providing services for external review or state IDR determinations. There's no minimum payment threshold required to pursue the IDR process. Generally, IDRs must be separately initiated with respect to each item or service subject to the Act. However, under the interim rules, multiple items and services can be batched together as long as certain criteria are met. That includes they are billed under the same provider number or tax ID number. The payment would be made by the same plan. Services are billed under the same service code or a comparable code under a different procedural code system, and services were furnished within the same 30-day business period. So once the IDR is commenced, the next step will be to choose an IDR entity. Within 3 business days, the parties must jointly select an IDR entity. If they can agree on one, then that entity will be the one who resolves the dispute unless there is a conflict. If the parties do not make a joint selection, within 6 business days of initiation of IDR, HHS may select, and it looks like it will just be a random selection. Each party has to pay a non-refundable $50 administration fee at the time the IDR is selected. And then not later than 10 days after the selection of the IDR entity, the parties must submit to the IDR an offer for payment amount expressed as a dollar amount and as a percentage of the qualified payment amount. For plans and issuers, the offer must contain information on coverage area, relevant geographic region, whether coverage is fully insured, and the relevant QPA. And then for providers, this offer has to contain information on the provider's practice size and specialty. At the time they make the offer, both parties have to pay upfront the full IDR entity fee. And then the IDR entity will refund the fee to the prevailing party, or if there's a settlement reached during the process, it will refund half to each of the parties. Settlement negotiations are still encouraged even after the IDR process has been initiated. The IDR entities have 30 days to make a determination, and the entity will basically pick one QPA or one of the offers submitted by either of the entities. Determination is binding and it's not subject to judicial review. So notably, it does not appear that the entity will be permitted to just devise a settlement amount independently. There's no averaging the 2 offers. The proposed rules do include a criteria that the IDR follows in making a determination. It has to choose the offer closest to the QPA, unless credible information on any certain subjects clearly demonstrates that QPA is materially different from the appropriate payment. So things that they'll look at include the provider's level of training, experience, quality, and outcome measurements, the parties' respective market share, the acuity of the individual receiving the service and the complexity of the service, the out-of-network facility's teaching status, case mix and scope of services, the parties' good faith efforts to enter into a network agreement, and contracted rates between the parties in the previous 4 years, if those are available. The IDR is expressly prohibited from using usual and customary charges or the charges that would have been billed had the act not applied, or charges paid by Medicare or Medicaid. The IDR has to explain its decision in writing. And if it does not choose the offer closest to the QPA, then the decision must include an explanation of the specific determination supporting the decision. So as I said before, determination is binding, not subject to judicial review unless there is fraud or misrepresentation during the IDR process. There's a cooling off period. Under the rules, an initiating party may not submit another IDR initiation involving the same party and the same or similar item or service for 90 days. And then for claims that are batched, the IDR has to make different payment determinations for each eligible item or service. They might also charge a higher fee for batched IDRs. And the party who pays the IDR fee is the party with the fewest determinations in its favor. So obviously a mouthful, a very complex process that will come with growing pains, I'm sure. And so the question will just be for providers and plans, whether the burdens of this process are worth any benefit. So that remains to be seen. So quickly here, I know I need to turn it over to the other presenters. The No Surprises Act also calls for auditing of health plans and health insurers to ensure compliance with the requirement. The Secretary is supposed to audit a maximum of 25 health plans and issuers per year. And then if there's a complaint, the Secretary is authorized to audit a plan receiving complaints. There's also certain disclosure requirements for both plans and issuers and providers. Plans and issuers have to make disclosures about the Act's prohibitions against balance billing on their websites. And then it has to provide insurance cards with deductible and out-of-pocket maximums as well, and contact information for consumer questions. Beginning no later than January 1st, each healthcare provider and healthcare facility has to make publicly available and post on a public website a one-page notice in clear and understandable language, the requirements and prohibitions of such provider or facility, any state law requirements regarding amounts provider can charge, and information on contacting federal and state agencies if the individual believes the provider has violated the act. But HHS has recognized that this, also in addition, you have to notify patients of a good faith estimate of estimated charges for scheduled covered services. However, given the complexities of doing that, of disclosing the good faith estimate, HHS has acknowledged that compliance with the requirement will be difficult and has chosen to defer enforcement pending rulemaking, and will announce to the providers and facilities at a later date when enforcement will commence, and has indicated that it will give a reasonable amount of time to comply with the good faith estimate requirement. How is the Act enforced? The Act permits states to require providers to adhere to provisions and enforce compliance. In absent state action against any violation, the Secretary of HHS is authorized to issue civil monetary penalties of up to $10,000 per violation. Just quickly, Oklahoma does not have corresponding legislation on surprise medical bills. The legislature did pass in this last session the Oklahoma Transparency in Healthcare Prices Act. It's a bit broader than federal pricing transparency laws, The act took effect on November 1st. It's codified in the insurance code, Title 63 of the Oklahoma statutes. And under the act, a healthcare provider has to make available to the public in a single document the healthcare prices for at least the 20 most common healthcare services the provider provides. They have to be identified by CPT code and then include just a plain English description. Healthcare provider is broadly defined as person who is licensed, certified, or registered by the state to provide healthcare services, or a medical group, independent practice association, or professional corporation providing healthcare services. Federal law applies only to physicians. And healthcare price means cash price that the provider or facility will charge a recipient for services rendered. Healthcare price is the price charged for the standard service for the particular diagnosis and does not include any amount that may be charged for complications or exceptional treatment. The act also requires healthcare facilities to post the 20 most used diagnosis-related group codes per specialty used by the facility, as well as the 20 most used outpatient CPT codes. These have to be identified by code and English description and has to be updated at least annually. Facility is defined as a facility licensed or certified by the State Department of Health, but it does not include nursing care facilities or assisted living or home care agencies. Interestingly, there is no enforcement mechanism in the act. There is no agency tasked to enforce it. So the law does expressly state that nothing in the act shall require a facility or provider to report its healthcare prices to any agency for review. And it doesn't limit a healthcare facility or healthcare providers' prices or changes healthcare prices in any way. It's just a matter of making sure that the patient is informed. So that's all I have for my portion of the presentation. I'm going to turn it over to Allison, who will focus on some mental health parity issues and other transparency issues. So here's Allison.
Good afternoon. Excuse me. Yes, I am going to focus on some prickly pricing issues. And I say prickly because the first issue, mental health parity, will impose yet more administrative burden on employers with respect to their employee benefit plans. And the latter two, reference-based pricing and Coveted surcharges, are just kind of controversial. We'll start digging in with the first prickly pear. Mental health parity has been an objective codified in 1996 first by the act that prohibited employee benefit plan sponsors, certainly of large employer sponsors, that means 50 plus employees, who happen to offer mental health benefits in the first place, from imposing higher annual or lifetime dollar limits on mental health benefits than those applicable to medical or surgical benefits. And then in 2008, the prohibition was extended to differences between mental health and medical and surgical benefits in the nature of treatment, cost sharing, and network coverage limits. So it went beyond just prohibiting that difference with respect to higher annual or lifetime dollar limits. And further, the 2008 Act added substance use disorders to the mix in terms of the parity objective. Then in 2010, the Patient Protection and Affordable Care Act, the ACA, Obamacare, defined coverage of mental health and substance use treatment as one of the 10 essential health benefits that, these essential health benefits that are required to be covered by the individual and small employer market insurance, and does not apply to the large market group. The Department of Labor has been focusing on mental health parity compliance in recent years. And in a few years ago, the Department of Labor, HHS, and the IRS, or the Department of Treasury, who are responsible for enforcing mental health parity, developed and released an online self-compliance tool that plans can use to evaluate and measure their compliance with mental health parity law in 6 benefit classifications. There is a new requirement. As of early this year, the Consolidated Appropriations Act now requires plans and issuers to conduct a comparative analysis of mental health and substance use disorder treatment limits versus medical surgical treatment limits that are non-quantitative. And then upon conducting the comparative analysis, the plans and issuers must be prepared to provide that information, the analysis, as well as related information to the government and others upon request. So an NQTL non-quantitative treatment limit is basically a limit on the scope or duration of benefits that is not expressed numerically. So that's like medical management standards, prior authorization requirements, and methods used to determine provider reimbursement rates. The agencies are required to request at least 20 plan analyses per year, and the Department of Labor has already begun doing so, mostly in the context of its audits of plans for other reasons, but it also has begun to request the analyses from plans who are not currently under any investigation. Beyond the agencies, plan participants and authorized representatives, such as out-of-network providers, may request and receive plans comparative analyses. The self-compliance tool that was released in 2018 is a very useful guide for preparing the comparative analyses on the NQTLs. It has already in place a suggested 4-step process for conducting that kind of analyses based upon the 6 benefit classifications that are at issue. It also provides examples of the kinds of documents and information that will be needed to support the comparative analyses, such as samples of covered and denied mental health, substance use disorder, and medical surgical claims, claims processing policies and procedures, instructions to third-party administrators, documents that will support any type of study, or meeting minutes, decisions referenced by the analyses. There are 9 elements to the comparative analysis. The plan or issuer is going to need to identify the specific NQTL at issue, plan terms, relevant policies, the mental health, substance use disorder, and medical surgical benefit to which the NQTL applies within one of the 6 benefit classifications. Plan or issuer will also need to provide the factors, the evidentiary standards, sources, and strategies used in designing and applying the NQTL, and an explanation of any relative weight applied and why, as well as the definitions used to define the factors or standards in a quantitative manner, variations in application of guideline or standard to the mental health substance use disorder versus medical surgical benefits and how that was established. The plan will need to identify the nature of the decision makers, timing of the decision, and qualifications if the NQTL is based on a specific administrative decision, qualifications of any expert upon which the plan relies, the extent of that reliance, and then, of course, a reasoned discussion of the plan's findings and conclusions about comparability as between mental health, substance use, and medical surgical treatment limits. And then finally, the date of the analyses and the name, title, and position of all the individuals participating. In the event that the comparative analyses is deemed deficient by, say, the Department of Labor upon first looking at it, the plan will be given an option to correct any deficiency, including by providing a supplementary or additional comparative analysis within 45 days. Thereafter, if the Department of Labor, though, makes a final determination that the comparative analysis is non-compliant, then the plan must notify all the participants of this non-compliance within 7 days, and the Department of Labor will share its findings with the state where the plan is located. There are potential penalties at issue as well, up to $100 a day. Not clear to what extent that these penalties are likely to be applied, but they are possible. Further, the agencies are going to need to issue an annual report once they gather information, sufficient information from the comparative analyses. They'll issue a report to Congress and to the public that includes a summary of the comparative analyses and identify each plan or issuer receiving a final determination of non-compliance. The first report is coming up due December 27, and then thereafter reports will be due every October 1st. The agencies are also required to issue guidance as to mental health parity compliance. The first set of guidance is due this next summer, 2022, in which the agencies will need to provide examples of prior findings of parity compliance and non-compliance, recommendations encouraging the use of internal controls to monitor compliance, information about process and timeline for participants to file complaints and where they can file these complaints. And then separately, there is no timeline for this guidance, but the agencies are eventually will be required to issue guidelines on the NQTLs in particular, and giving examples and methods for determining the appropriate types of non-quantitative treatment limits for both mental health, substance use disorder, and medical surgical benefits. Finally, tips to consider when you're conducting the comparative analysis. Consider getting a third-party administrator involved who will be able to assist you with that process. And then secondly, start the process, the analysis right away. Inevitably, there may be delays, and if you get that process started right away, then can show good faith in the event the Department of Labor comes knocking and you're not ready. Also, it's useful to begin the analysis focused on what the Department of Labor has focused upon in enforcement actions of late, and that is prior authorization requirements for in-network and out-of-network inpatient services, concurrent review for in-network and out-of-network inpatient and outpatient services, provider admission standards, including reimbursement rates for network participation and out-of-network reimbursement rates. And finally, it would be useful to prepare a written compliance plan that outlines internal protocols, in particular to ensure that your service providers, your TPA, provides the documentation that the plan sponsor ultimately is responsible for submitting in order to ensure compliance. All right, the next prickly pear, reference-based pricing. So it's no secret that the US has a bit of a healthcare cost problem. It's got the highest cost of healthcare in the world, over 10,000 per capita, 3.5 trillion per year, and not the best, not really getting our bang for our buck, as the health outcomes tend to be worse than in many developed countries. An explanation for this, just as in a nutshell, that is not really in dispute, is that there's some misplaced or lacking government regulation that allows for non-standardized and unchecked system. And in this void, you have profit-driven interests, insurance, big pharma, mega healthcare entities. The three main cost components, big parts of spending on healthcare in the US, are administrative expenses, for-profit interests, which otherwise known as greed, overutilization of costly medical technology. And there have been various proposals of how to address these things in administration. Providing some kind of standardization is pretty key, and that will likely involve the federal government getting involved to do that. That hasn't really happened yet. And then for-profit interests, price regulation is a proposed solution, though there is concern about unintended consequences. And then the real sticky one is overutilization of costly medical technology, what to do about that. What role the federal government does play with respect to healthcare cost is arguably kind of compounds the issues. So the federal government, of course, is focused upon providing insurance through Medicare and Medicaid, and it pays a set rate for each service provided to patients covered by Medicare. Well, this leaves providers in a place where they end up charging multiple times more than the federal government for the same procedure through private insurance or employee benefit plans. So there's a wild difference between prices. The private rates typically are described as, in 3 categories. You've got your billed charge, and that's the amount the provider determines to bill. If it's a hospital, it's usually the bill is the rate on a charge master, which is the charge master is what sets the rates or the prices for all the treatment and items supplied by the hospital. And you've got your network rates. Providers contract through preferred provider organizations to provide preferred rates, and that's called a network rate or contract rate. And then you have UCR, usual, customary, and reasonable rate, and that's the average charge of providers in a geographic area, and that's typically applied to non-network services. And of course, you have the opportunity for negotiation of rates with providers, something in between the billed charge and say, for example, the usual, reasonable, and customary rate for out-of-network services. So what is reference-based pricing? Reference-based pricing is something employee benefit plans, in particular self-funded plans, are checking out as a cost containment tool. It's pricing based upon a multiple of a referenced objective value, such as Medicare rate, provider reported cost, average wholesale price, third-party database price. And when it's based upon Medicare, which is probably what most people hear it as or is used in a lot of plans, then it's typically a multiple of Medicare that is 1.2 to 2 times Medicare amount payable for a particular service or supply. So you might have heard it described as 120% of Medicare, 140% of Medicare. And this typically replaces a UCR rate for non-network services. As I indicated or mentioned, self-funded plans are the ones who are able to utilize reference-based pricing. And so a self-funded plan is one that's funded by the employer. And then you have an insured plan, which is funded through an insurance contract. And about 58% in 2016, 58% of employees were covered under self-funded plans. Self-funded plans, unlike insured plans, do not have access to a vast, unlimited pool of funds for claims payment and administration. It's not insured. There's no insurance contract to protect it. And so it's left at the mercy of unpredictable and sometimes just exorbitant prices for medical services. Reference-based pricing allows self-funded plans to provide more affordable and predictable claims payment and administration of their plans, especially for costly procedures. A lot of self-funded plans will use reference-based pricing to pay for non-network facility or hospital charges, for example, while continuing to use a network arrangement for other physician services. Other plans, more increasingly, are forgoing network arrangements to pay covered services at all and just using the reference-based rates. And again, this is self-funded plans, not insured plans. It's increasing in popularity among self-funded plans. In 2016, 60% of plans who were subject to a study indicated that they planned on using reference-based pricing in the next 3 to 5 years. And then as association health plans expand and the number of employees covered under self-funded plans increases, and it is, then this pricing model may become more popular. Unsurprisingly, hospitals and facilities, health systems do not like reference-based pricing. The big concern about it is that it allows for or exposes the patient to balance billing. When you have a reference-based pricing for non-network services, then the patient is left with the bill, which can be, many times more than even the Medicare amount times 2. And so in that position, of course, hospitals or providers are soon will maybe be prohibited from balance billing in some circumstances, and otherwise, even to date, are loath, of course, to charge Jack and Diane $3 million on their balance, to collect that from them on their balance bill. And so there ends up being a lot of write-off in hospital debt. The AHA, American Hospital Association's position statement succinctly states it, reference-based pricing is bad for patients and the hospitals and health systems that serve them. Self-funded plans, many self-funded plans disagree. At least from their perspective, it's a useful cost containment tool. And it remains to be seen how popular it will become. All right, the third prickly pear, COVID surcharges. So Delta Airlines made news this summer for imposing a surcharge as a condition of eligibility of unvaccinated employees for health benefits, and by unvaccinated, not vaccinated for COVID-19. And since that time, other employers have wondered whether they might follow Delta's lead, certainly before the OSHA standard got onto the horizon. And have questioned whether it's legally sound, in particular, whether it complies, whether a COVID surcharge would comply with HIPAA and the ACA's wellness program requirements, and not be discriminatory under the Americans with Disabilities Act. Health benefits analysts and consultants across the country are pretty skeptical about it. So the HIPAA and the ACA prohibit discrimination with respect to premiums, contributions, and benefits under a group health plan on the basis of any health factor. There is a narrow exception for a qualifying employee wellness program. And in particular, for example, a smoking cessation program. That's the comparison that Delta made with respect to its COVID-19 surcharge, is that this is like a smoking cessation wellness program. Well, smoking cessation programs are expressly permitted and under HIPAA and the ACA, and smoking and these kinds of programs are expressly exempted from discrimination, prohibited discrimination under the ADA. So the comparison is perhaps not the best one. So there's a participatory wellness program and a health contingent wellness program. A health contingent program, wellness program, which would be the one at issue with respect to a smoking cessation program or a COVID surcharge, is one that requires an individual to satisfy standard related to a health factor to obtain a reward, and reward is defined to include a penalty. So the penalty being needing to pay more premium for contribute more if you are not vaccinated. A health contingent wellness program, though, requires that it provide a reasonable standard. It has to be based upon reasonably designed to promote health or prevent disease, and it would need to have a reasonable chance of improving the health of or preventing disease in participating individuals, not be overly burdensome, not be a subterfuge for discriminating based on a health factor, and not be highly suspect in the method chosen to promote health or prevent disease. And this is a difficult standard to satisfy, and surely would raise some concerns with respect to COVID-19 vaccination, given the different perspectives on that issue. Furthermore, though, the program you have to provide an alternative standard for a health contingent wellness program. So you have to, or allow the standard to be waived. So it's not clear that, certainly in the context of a smoking cessation program, for example, an alternative standard would be to, upon request, to allow an individual to watch informational videos or use a nicotine patch or something like that. It's difficult to imagine with the COVID-19 vaccine. I don't know. But regardless, in essence, you wouldn't be able to you wouldn't be able to impose the requirement if the participant requested an alternative. And then third, that under a wellness program that relies upon a medical examination or an inquiry, for example, proof of vaccination, and not simply an affidavit of someone saying I am vaccinated or I'm not vaccinated, is subject to the ADA rules with regard to voluntary wellness programs. So in that regard, you have to not require an employee to participate and fulfill a number of other requirements. And again, the objective seems to be lost at that point. If the if the surcharge is compliant with the wellness program requirements. Separately, there are concerns as to whether a COVID surcharge would run afoul of the Americans with Disabilities Act or the Affordable Care Act, which prohibits discrimination with respect to eligibility for employment or benefits of employment on the basis of disability. These laws are still in effect during the COVID-19 pandemic. And so employers should be mindful of their application and is not excused from compliance with the law just on the basis of agency guidance, that especially agency guidance that's contrary to law or arbitrary and capricious or issued without authority. Would have to rely upon the plain terms of the ADA, and then only if the ADA is ambiguous and is agency interpretation through regulations given deference. And its facts, frequently asked questions, and other informal guidance doesn't get any deference at all. So COVID surcharges, aside from raising issues, questionable compliance issues under the HIPAA and ACA rules for wellness programs, are pretty questionable under the ADA and ACA with respect to disability discrimination. Certainly something that an employer should be mindful of and explore if they are considering such a measure. All right, I am going to move on to pass the torch, I should say, to Bill, who is a manager at BKD and will be talking to you about CMS new reporting requirement.
Okay. Good afternoon, everyone. I will be brief with the amount of time that we have left here. But I'm Bill Clark. I'm Managing Director with BKD in BKD's Tulsa office, and I spend most of my time working with providers on Medicare and Medicaid reimbursement issues is what I really focus on. And today what I wanted to talk about is CMS Transmittal 17. It was actually published about a year ago in November 20th, 2020. It has not been finalized yet, but providers need to be aware of this because it changes several things related to the amount of information that needs to be reported, and particularly some of the supplemental schedules to the Medicare cost report. So Transmittal 17 actually added 3 cost report worksheets and revised the worksheet instructions for 12 of the worksheets. What I'm really going to be focused on today is it provided a revised worksheet S10, so standard reporting for worksheet S10, which is what hospitals use to report their charity care and bad debt, which goes into the uncompensated care dish payments. It expanded the information that's required for Medicare bad debts and also provided a new DISH exhibit to report information related to Medicaid eligible days, which goes into both the Medicare DISH calculation and also the LIP calculation for your rehab units. So this is the new standard form for Medicaid eligible days. A lot of it is just, it's just standard patient demographic information. But there are some things to kind of take a look at here. One of the things they are asking for is state eligibility code. So, you know, if it's a Medicaid eligible patient, they need to, there are certain program codes that are approved programs under Title 19, and then codes depending on the state which are not approved under Title 19. So what they're looking at there is they're going to be looking at what the eligibility code is for this patient, whether it's under Title 19 or not. And also they're going to be looking for Medicare eligibility. If it's a DISH eligible day, the patient cannot have Medicare, but if for some reason the patient had Medicare for part of the patient stay and not the full patient stay, then they're going to want to see the Medicare eligibility information there. The Medicare Bad Debt Log. So this is the old form. There were 10 columns required in the form, at which some of this information is already kind of cumbersome and difficult to obtain out of hospital patient accounting systems. And now we'll see under Transmittal 17, the form actually expands to 25 columns. So again, standard patient demographic information. But then,
hey, Bill?
Yes.
We are unable to see the slides. It's just on your presenter or your PowerPoint view of just your bio slide. So I'm not sure
Oh, really?
If actual slideshow or not, but.
Interesting. Okay. Let me see here. I apologize for that.
Yeah, there we can see that one now. I don't, if you just want to make it full screen or.
Yeah. Can you see it now? Let's see.
We can see it, but it's just, there we go. That's perfect.
Okay. Sorry about that. I apologize. What I was moving on to was taking a look at the Medicare Bad Debt Log as it stands now. There are 10 columns of information, data elements that are required. And now it's moving on to, if Transmittal 17 is finalized, 25 columns of information. Some of this that is being added is they already asked for Medicare remittance advice date, but now they're going to be asking for Medicaid remittance advice date. And also if there's another secondary payer, if they have Medicare primary and another payer secondary, they're going to want that remittance advice date as well. The beneficiary responsibility, date of first bill for the patient, which is already a requirement. They're going to ask for the AR write-off date, which is a new data element, along with the collection agency sent date and the collection agency return date, and the collection effort cease date, and then the Medicare write-off date. So really, if you know the Medicare bad debt rules, the debt has to be deemed uncollectible and all collection efforts cease in order for it to be claimed as a Medicare bad debt. So what they're trying to get to here is identifying that last date of collection effort. So some of these dates can be duplicative. You know, if your Medicare write-off date and the collection effort date cease date are the same, and same with the collection agency return date. Those may all actually be the same date. Moving on to the charity care requirement. So this is a new standard form for reporting charity care on the S10. And CMS has asked for charity detailed patient listings for charity care for the past few years to support the uncompensated care that's reported on S10, but there hasn't been a standardized format historically, and so it's kind of been all over the place as far as what the MACs are asking for and what hospitals are providing. So this provides a new standard for reporting charity care, and it's going to be Exhibit 3B of the cost report supplementals. So again, we're looking at some standard patient demographic information, insurance information. They're going to take a look at, they want to know if was the patient approved for charity care and under which policy was the patient approved for charity care. They ask for some information related to non-covered charges, which aren't allowed unless it's Medicaid non-covered charges, and those are covered in your policy. Then those are allowable. They'll ask for uninsured discount information. I see that get missed fairly often as providers are reporting their charity care. If you have an uninsured discount where, say, you write off 40% of total charges off the top for uninsured patients, that uninsured discount can actually be included as charity care here for the worksheet S10. Then ultimately what they're trying to do with all of this is that they're going to try to reconcile the total charges down to the amount that was written off. That's not always going to flow perfectly due to ins and outs that are always posted on a patient's account. But ultimately that's what they're trying to get to here, which theoretically should make the S10 audits go a little smoother going forward. If you've been through an S10 audit, you know that they can kind of drag on, and I have some that started in March of this year and are still ongoing today. So, and then for the total bad debts, again, a standard format for reporting the total hospital bad debts, and these are the data elements they're asking for here. I'm not going to go through all of them, but again, it's some standard patient demographic information like the other listings, and then also charge information, payments, contractual allowance, write-off amounts. So again, they're trying to kind of reconcile all of that back to the total charges for the patients. These are just, this just kind of illustrates all the different data elements that go into these patient listings. And a lot of them kind of overlap, and some of them are actually common throughout all four of the detailed patient listings: Medicare bad debts, the S10 bad debts, S10 charity, and Medicare DISH. So maybe just kind of think about, as you're starting to pull the information, is there a way that, all of the information can be pulled out of your system and then other sources, and then kind of gathered and compiled using that, that one standard data set to provide all this information that Medicare's going to require. And I'm happy to talk through that with anyone who might have questions on strategies and ways to kind of go about that. So, and looks like we are just about right on time. That is all the time that's all that I have. If there are, I haven't seen if there's any questions come through, or it's like what we might do is, since we are just right up on the hour here, if there are questions that come through, or if you do have any after we get off the webinar, feel free to submit those, and we'll definitely get back with you. So thank you very much.